Well, thank all of you. I mean, that was incredibly rich and I think very helpful to the committee. And what I would like to do now is open up the floor to the committee members to see if there are any further questions that they would like to ask. I mean, you all have said so much, it's hard to figure out what more they could find out. But in any event, I will open the door to my colleagues. Lily?
So I have two questions. But first, I wanted to comment that Mrs. Whittemore's conversations with her seatmate on the plane are exactly the type of conversations I've had coming here to DC when people ask me, why am I coming here? And I tell them I'm going to a meeting and we're going to talk about chronic fatigue syndrome. Had several people say, well, I have that maybe. And then I start talking to them and, well, anyway, it gets interesting. And it gets into the whole issue of how do you define fatigue and what it means, et cetera, et cetera. But the two questions I had was, first, in terms of post-exertional malaise, I was wondering if the people on the panel could describe their personal or their children's experience in terms of the timing of post-exertional malaise, meaning when does it start, what, if you have a sense when your peak is and what the duration is, and if that varies for you depending on the stressor. And then my second question is, Mrs. Whittemore talked about the name, but I don't think the other three people commented on the name as much. And if you have any comments, I'd like to hear about it.
Okay, I'll start. As far as post-exertional malaise, onset can be immediate, it can be delayed. I've seen it delayed in my sons up to 3 days even. Duration, I haven't figured out a way to predict how long it's going to last. Type of stressor, it can be cognitive or physical, and it can be just as debilitating for either one. Name, oh my gosh. Chronic fatigue syndrome is a really crummy name. It's a really horrible name. It's a lousy name. I could go on and on all day. But I'm not entirely sure what it should be.
So on the post-exertional malaise, you know, after 30 years, it's still very hard to judge. You know, it just kind of depends on where I'm at in, you know, my illness. Just the flight coming here, I did okay Saturday after flying in. I did not get out of bed yesterday. I kept telling myself I was going to, but I just had no ability. I couldn't get up to eat, couldn't get up to get water, and you're just kind of in, I call it the zone, to where you literally can't make yourself do anything. There's times when that malaise won't happen for a couple of days, and when it does, it may last 3 days. So I think it just kind of goes with the wax and waning of the illness, and depending on, you know, whether you're actually at a peak physically and mentally when whatever stressor hits you. As far as a name change, you know, I'll say it that for many years, I would say, look, I don't care what you call it, as long as somebody's doing research and you're trying to find answers. But after a lengthy period of time, it is clear that the term chronic fatigue syndrome hurts us, hurts the patients. I think it hurts the researchers when they turn in, you know, a grant and it says chronic fatigue syndrome on it. It does not get funded. And I'm sure you could ask some of the people at the table. So I don't care what it's called. I'd like to see it, you know, not be chronic fatigue syndrome anymore. Possibly Ramsay's disease would be a good idea. Thank you.
On post-exertional malaise or collapse, I agree with everything Denise and Bob have said so far. Personally, I'd add that I've forestalled it sometimes with symptoms that resemble descriptions I've seen of roid rage. They don't prevent PEM, but when I'm truly angry about something and manic, it forestalls the PEM and makes it all that much worse when it finally catches up with me. It's just that much of a bigger cliff. That hasn't happened lately. It's been a few years. As far as the name, again, I agree mostly with Bob. By any other name would suck as bad, to paraphrase the bard. Since no one's asked, I'll tell you what I think the illness is. It's autoimmune, not because I can prove that, but because we have a chronic illness with lots of immune functions that has a relapsing and remitting course. The clinical path seems more likely autoimmune to me. And here's what I can prove. Historically, we spent over 100 years trying to prove infectious agent theories and trying to prove a number of psychosocial theories, and all of them have failed. Autoimmunity may not be the right model, but it's the only one we haven't aggressively pursued. Here's my crackpot theory. Energy comes from the mitochondria. It's 90% of our cellular energy. And what we just learned in real research, in other words, research that's not related to CFS, the places where research actually happens, there's intense interest in mitochondria in the last 10 years. First, because we found it helps influence or regulate apoptosis, and second, it sends out innate immune signals that are proteins formed on the outer surface of the mitochondria. Gee, what if it's constantly signaling the body's system to send an inflammatory response to fight an infection that's not there, and it's so busy doing that that it can't go through the Krebs cycle properly in a timely fashion? So I'm not qualified to say that, but I said it anyway, just because. Thanks.
And I would agree with you, but one of my slides actually says, have we paid enough attention to mitochondrial disease? Because anytime there's more than one system involved, and there's as many as 3 systems involved, then think mitochondrial disease is a statement right off of the United Mitochondrial Foundation website. So I think we definitely need to pay attention to that. In terms of the crashes that occur, I would say about 24 hours after the stressor, but it could be immediate. So it's not as if there's really a way to prepare, perhaps a little bit of prevention, maybe. Individuals who, and this is where this energy conservation idea comes from, who try to conserve their energy, try to avoid upsetting situations, extreme heat, extreme cold, and so forth. And flying, it's not surprising, Bob, that you had a problem with flying. The reason my daughter isn't here is she can't fly at all without having seizures. And it's the low oxygen level. So getting oxygen to the tissues is really important and could be potentially part of this problem. Thank you.
The order is Margarita, Betsy, and then Nancy.
Thanks so much for your presentations. It was really very helpful. And could you speak a little bit about the tension between a concise, simple, easy-to-grasp definition of the illness and the lack of specificity that might perpetuate a broad rather than a very specific set of symptoms, and the worries about exclusion and not being able to identify critical symptoms if you go with a very narrow definition? So that tension that happens between the two.
Get it, Joe.
I think lupus is a great model of this illness because it's everywhere and nowhere. One of the huge difficulties in calling this an autoimmune disease, just to argue with myself, is that the autoimmune diseases are all identified mostly by an area of the body or by their pathology. The pathology is not the illness. It's just a shorthand for finding the disease. And when there's no pathology, Typically, no one tries to invoke the autoimmune model. So it's very hard to be specific. It's hard to be specific with lupus, as I understand it. It takes years just to identify it because medicine is analytical. It wants to be specific and narrow things down to a specific area of the body or organ system or something like that. And that's impossible to do with this illness. So your question, it's really hard to answer. The symptoms are all we have, and the symptoms are truly misleading. That's why I think ideas are so important, and we need to come up with an idea, a hypothesis that makes sense, not because it's perfect, but because it's a framework to investigate the illness. Someone still wants a name. We could call it a presumptive autoimmune disease, presumptive systemic autoimmune disease, because the mitochondria are everywhere, and the energy they do or do not produce. I know, I'm sorry, I'm getting out past the science here, but I'll let someone else answer.
So in the past, I think that's been one of the concerns for instance, for not changing the name, that some subgroups would be left out. And instead, I think that you can identify the areas of pathology in this disease and subgroup individuals and be inclusive in doing so. Is that helpful? So if you have, for instance, mostly neurological issues, mostly endocrine issues, mostly immunological issues, they can all be included in a definition, but then subgrouped out. Each of those can be subgrouped, and they do that with other diseases. Again, like you said, with lupus, so that they have lupus that just impacts mainly the skin, and then you have lupus, a different type of lupus. So that's one model. Another model might be the mitochondrial model, where everyone understands what mitochondria is in every cell in the body. And so it isn't one particular area of concern, or rather it's concern for the entire individual.
I agree with subgrouping and subsetting for this illness. And as a start, as a beginning, I don't think that this committee should be charged with coming up with a perfect definition or a perfect answer for a name that describes the illness. I think that your charge is to do your best to take the knowledge that we have, take the information that you have, and just go from there. And I think that having that first step will lead to the second and third step, and we'll get to the point to where we'll have like cancer, and then 50 subgroups and subsets of different varying cancers.
My comment is fairly broad in that I referenced earlier my son's illness is characterized by the hallmarks of severe cognitive impairment and post-exertional malaise or collapse. And to me, it's very important that that be what is highlighted for my son's illness. I think it differentiates things from idiopathic chronic fatigue or somebody who thinks that he had this illness at some point.
Again, thanks to all of you for sharing stories, information, and helping us. I have two questions, and Denise, one of your slides provoked this first question. It was on my mind anyway. So you had a slide where you talked about your son's ability to engage in a one-on-one conversation was about 3 minutes long or less, and to do any kind of cognitive work would be 20 minutes tops. Is that right? Does that sound about right? So my question to you is, if he goes beyond those limits, and I'm sure those limits vary from one day to the next, then, and actually it's my question to all of you, it's question number one, if they go beyond those cognitive challenge limits, what happens? And then my second question to all of you is, the term post-exertional malaise is something that is not well understood by a lot of individuals. That term malaise kind of hangs people up. We all know in the CFS community what it means, but when you venture outside of that community, it can be problematic. And I'm just curious if you had suggestions or your own personal affection for some other term that might describe what you or your family members experience.
Most of the time, in fact, you heard me switch back and forth between post-exertional malaise and post-exertional collapse. I think malaise, to the layperson especially, is a total misnomer. They think it's just, it comes from the French, mal à l'aise, ill at ease. Sorry, has nothing to do with the crash or the precipitation of a crash. So I prefer post-exertional collapse. That's me. As far as if my sons go beyond the 20 minutes, maybe 3 times a week to learn new material, makes it awfully hard to get an education that way. It's impaired cognitive function, as in can't choose a drink, can't answer yes or no, and impaired physical function as well.
I just like to say that in looking again at mitochondrial disease, that they just put post-exercise fatigue, and everybody seems to understand that when you run out of energy, you run out of energy, whether it's in your brain or your heart or your limbs. So I didn't understand why we wanted to call it something different than what it's already been termed and what other doctors already recognize. So that, I think the more that we mainstream conversations, words, terms, things that are already understood and used by physicians in other diseases, that the easier it is to transfer that knowledge. So.
Did you say you don't want to change the name?
No, I said I think it's everyone, there's already a term for it. The post-exertional malaise is post-exercise fatigue in diseases that are better understood. And if that's the case, then maybe we ought to use the same terminology, right?
Yes, the term exercise is something that's not understood outside of some of the people in this room and people watching and listening. They're going to take it to be ran a marathon, climbed a mountain, etc. Please be very careful with the term exercise.
You're next. And then Marshall.
Yeah, I think it's post-effort rather than exercise. It's post-effort. But anyway, actually, I wanted to say to Joseph that I'm so glad you lost your notes. Because honestly, it gave the committee a chance to see someone working their brain, and you did it, but you had to struggle to pull it off. And I know it wasn't deliberate, but thank you for that. And we'd like your notes. Okay, I think it'd be fantastic. But that, I was very touched by everyone's testimony today. And I mean, you know that I've heard this story a few times before. So 30 years into this. It still, gets my heart every time. It's just really, really hard to hear you struggle, and as someone in the field this long, to still be here. It's very, very difficult. I would love, and I don't know how the committee feels about this, and I certainly don't want to make poor Cece's gang work this hard, so I'd rather one of y'all organize this and then send it in. But I'd love to know what the patient community thinks the name should be. And I know that there's no consensus here, but it would be tremendously helpful, I think, to this committee's process as we contemplate the current name and any possibility of changing the name. If there's an obvious direction to go, that would be very, very helpful. So I throw it back to you, Joseph. Sorry about putting you on the hot spot there.
No, that's all right, thanks. I'll remember to forget my notes in the future.
On the name change, and the only reason that I'm saying that is because I think we have to have a new start. We have to get rid of what didn't work, what doesn't work. I'm not talking about the research now. I'm talking about the perceptions of the illness. And since we're saying to the world, you've been confused, it's not what you think, then I think changing the name helps do that very thing. So one of the things, and I guess I would just suggest, is that rather than say, hey, let's get 1 million different choices for 1 million different names, is there a possibility to, come up with 4 or 5 and then ask the world, or 3 or whatever. It's kind of like what we do with our 3-year-olds. Here's 2 really good dresses, just pick one, so that they don't pick something really bad, And I'm not saying that, I'm just saying it might be more appropriate, it might be more helpful.
Very,
Thanks.
very good point. Denise, and you said this, and I'm going to echo it, that in our recent CFI study, we did a cluster analysis of all the symptoms, and the neurocognitive and the immune inflammatory ranked as high as the fatigue. They equally impacted the level of illness, or the illness at all.
I want to come back 2 things. First of all, to what Denise said, because for those of us who are pathologists, we're always very interested in when there's more than one in a family. And I realize an N of 2 is not anything like a statistician happy. But are there, in your 2 sons, differences in the disease, in its onset, in its progress, and that come out?
Yes, there are. My younger son got sick before my older son did, as I said, and he had a very sudden onset. My older son had a gradual onset that I can date to about 15 months later. However, when my younger son got sick, they both were sick at the same time. The older one recovered, he did not. Differences in the illness, yes. Matthew notices his illness a lot more. My other son is very seriously ill, but he doesn't seem to, he can't remember from one day to the next if he feels better or not, or if he feels any different. Whereas Matthew can quantify those things a little bit more. I'm not sure if that's helping you.
My second question really comes to Annette, but I've heard over and over since I've come on this panel, and I come from a different universe entirely, but I run a department that has a very large faculty who are, as most biological scientists these days, on the prowl for any research dollar they can find. And they include people like Ian Lipkin, who's in our department. And what has not come to my attention is that there is any foundation, any attempt that seems to be attempting to haul new people into the field. When I read the literature, and it's one way of marketing devotion to the people who work in the field, the same names come up and again and again. But when research on Alzheimer's disease started, one of the things that got it off the dime was by having funds available, pilot funds, because no foundation can afford to do what the NIH does, to get people into it. And is this happening? Because right now, when you say chronic fatigue research isn't getting funded. Well, I think almost anybody would tell you that most of what's going before the NIH right now isn't getting funded. It's hard to know whether it's diffuse, except that what is clear is years ago you had an idea, you put it in a grant, people liked your idea, they gave you money to test it. Now you need preliminary data, and that's where the foundations and things become important. So what is this community doing to suck more people into it?
What are we doing to bring new people into it? And you're talking about individuals just within the community who might be interested in being donors? Is that your question?
Well, one is always looking for money. No, I'm talking about scientists. Obviously, you have to get donors.
Right,
And,
right. Okay, to bring new scientists in?
Yeah.
Well, I think it's really simple to bring new scientists in. When there's money, there's there's scientists and scientific interest. So really what happened to get Alzheimer's off is the president said, we're going to make this a priority. And when the Secretary of Health, Secretary Sebelius, said that autism was going to be a huge, she was going to make a huge push in autism, they put money up. So it comes
By the
down
way,
to
just
dollars.
correct one thing.
Yeah.
There was not $1 new of Alzheimer money, and that's not where it took off. The president made great comments, but all they did was rearrange the deck chairs in Titanic.
Oh. And you're right that there is there's a depression in the amount of money out there. But I think what we're talking about is the base at $5 million compared to other diseases, and whether you're talking about migraine or MS or whatever. When we look at some of those other diseases, and they're hundreds of times more dollars of funding. You ask yourself, how does the NIH make those decisions? What are they based on? So.
That wasn't quite my question. I don't know how the NIH makes its decisions, but if you take lupus, you take frontotemporal dementia, you take things like this. I mean, frontotemporal dementia doesn't run off your tongue. There have been patient groups, patient advocate groups that have raised money to provide researchers the $50,000 a year grants, usually without indirect costs, which our universities love, but we need every dollar, that actually can bring people with these new ideas that both Joseph and Robert have spoken about into the field. And is there a foundation, or is there an attempt to set up a grants program that will get people really going in new directions?
There are groups that are doing that. There are a few across the country, and there are people here in this room who can tell you about them, people on your committee who can tell you more about them. Open Medicine Institute, the Chronic Fatigue Initiative, the CFIDS Association, Cimarron. Yeah. But it's very difficult. One of the reasons that it's hard to get people in is the name of the illness. It's hard to find people who are willing to accept the challenge of this illness. I think that's part of it.
I was just wanting to say one thing. First, Annette's being shy when she's not speaking to being a person that knows how to take nothing and build something in an institution that really had no interest. And she did it very cleverly, putting seed money into junior investigators' pockets to bring them into an investigative team. I thought it was brilliant the way the WPI took the University of Nevada system and brought them into the fold. That was very, very clever. But in the CFIDS Association of America has been for decades providing very small, they don't have a lot of money, but they do have consistent money year after year to put some pilot money out there. I will also say that the CFIDS Association some years ago did a think tank on a thematic theme, so they did say autonomic and immune and so on, to try to bring in new applications. They brought in something like 40 new applications and only had the money for 3. And I always thought, oh man, there's 37 new people that we didn't ever bring into our field. So they have to be thinking about, how it was great to bring the 3 new ones in. I love that. And the Office of Women's Research on Women's Health at NIH did a similar thing with a pot of money about 7 years ago, and got a whole lot of applications, and I don't remember the number, and funded, I think, 8 of them. But there were, I mean, it was, again, they were mostly new people, which was exciting, but we left some people out in the dust, so there could be a more thoughtful way of how to take this kind of foundation money or federal money and seed new people and young investigators.
I recommend tried and true academic techniques, by which I mean subterfuge and obfuscation. We get new people by identifying areas of pure research that impact directly on CFS. We don't tell anyone that they're doing CFS research until they're in too deep already.
You know, Mike's question is a very good one. And I think about my original field, geriatric medicine, because we have similar challenges in terms of getting an adequate workforce to take care of patients and also attracting people to do research in the field. And, you know, first is you have to have people in academic medical centers that teach medical students, residents, fellows about the condition or, you know, the area of geriatric medicine you want them to be interested in. I mean, I got into the field because some people in the universities I attended told me about it, got me involved, and that's how I got into it. But I think with chronic fatigue syndrome at a lot of academic medical centers, there isn't like one person, researcher or clinician, that takes an interest in it and then teaches residents or exposes fellows, et cetera, to the field. And so it goes back sort of to the beginning where we're talking about educating physicians and other healthcare providers and researchers about the illness. The second thing is, in geriatrics, we did outreach with specialty societies. So other than just concentrating on primary care fields, there were people who reached out to the surgical society, to you know, hemonc, to nephrology, for instance. And we had people at UCLA in the fellowship programs from those specialties too. So one thing we've done somewhat on the CFS advisory committee, the federal committee, in the subcommittee, is to consider outreach to specialty societies, and that's somewhat underway, but it's stop and go depending on people's schedules and energy levels. And then on my other hat, as the vice president for the IACF-SME, you're hearing them talk about the meeting. I was trying to do some personal outreach to people who had written papers about CFS. Maybe they did one paper on it, comparing it to another group, say, and just trying to tell them that there is a society to support them, because a lot of times researchers feel isolated, that they're the only people in their academic medical center doing this. And not only that, their chief thinks that they're working on a field that isn't real. So, you know, they get that flack too from people above them. And then the last thing is that our IACF-SME, as well as some congressional representatives, are trying to get more funding via an RFA right now.
Again, I think when there's a home for this disease and a national home for this disease, you're going to see a lot more interest from individuals who say, oh, that's what I study. I study neurology or I study immunology. So I think it's going to be important.
Yeah, I wanted to address, you know, trying to do pilot studies and trying to interest, you know, new blood into the field. I think that in the last few years, the way that we have gotten new researchers and new blood into the field is by personal contact. And what I mean by that is that somebody's son has the illness, and they happen to know a researcher and you know, have that connection, and then they're able to kind of draw them in. You know, I'm affiliated, I'm not on the board, I'm not a member, but I'm affiliated with Cimarron Research, and I think they've been in existence for about 3 years, and their efforts are to do just what you're saying, which is basically to put up that pilot money and to draw some new people in. It just isn't that easy. People have a choice between, you know, getting into a field of chronic fatigue syndrome or going for, you know, cancer. And the big bucks is in cancer, and that's the avenue they're going to pursue unless there's some kind of personal tie. I mean, it's very difficult.
Are there any more questions or comments from the committee? Any final statements from our panelists?
Again, I just want to thank everybody for being here. I'd like to emphasize the point again about the patient community. They're very concerned with what direction this committee will go. And if you go back and you review the history of the way this patient population feels that they've been treated from any federal health agency, that is the concern. This room probably would have been filled without that concern. And, you know, I've tried talking with some of these patient representatives. I thought it was extremely important to be here today. I think that the only way that we move forward is by doing it together. You can't do it on your own. We can't do it on our own. So, you know, I hope that other patients will get involved and try to stay involved with anything that's happening with this illness within the federal health agencies. And again, I thank you all for being here. Thank you.
Ms. Lopez-Mahano?
Sorry. I want to thank you very much. Among other things, the opportunity for the Q&A with us, it's really meaningful. I have never been able to participate in something like this before, to have questions from you to me in a setting like this. And I think it's very valuable. I hope you've learned something. And if I can be of any further help, I'm sure everyone else, we'd all be more than happy at any point in time. Thank you.
Thank you. Mr. Lanson or Ms. Whittemore?
Well, I also would like to thank you very, very much and remind all of you of the number of people whose lives are going to be impacted by the decisions of this committee, and that when you make those decisions, ask yourself if this is going to help clarify the illness and get these patients treatment. Thank you so much for the opportunity to be here.
Think outside the box, not just for our sake, because we're just one small problem in medicine, but it's faced with a whole bunch of problems that, yes, money is a problem, yes, data is a problem, but the problem is really ideas. Ideas about how illness happens and what to do about it. The WHO, the World Health Organization, just issued a report saying, gosh, we spent all this time, all these years fighting infections, and now we have disease-resistant infections. What are we going to do now? The person who ushered along that report and wrote the foreword was a name you may recognize. The deputy director, one of the deputy directors of WHO, Keiji Fukuda. I was trying to remember his name. Was he that pitcher for the Seattle Mariners? No, of course he was he was the lead author of one of our most popular case definitions. He's figured out that we need to rethink a lot of medical problems, and we're just one of them. Thank you.
Well, I want to thank all of you, because, you know, you really have taught us a lot in this period, and you've given us various important responses to our questions. I also want to take this opportunity to say that we also very much appreciate the public comments that we're getting. We read them, we consider them, we pay attention to them. So this has been very meaningful and very helpful. So I know for some of you, I guess for all of you, actually, this has been an effort to get here. But I can tell you that at least from my perspective, it's totally worth it. So, because you have really enlightened a lot for us. So thank you very much. We will take a break now for 15 minutes and then reconvene to hear some of our other speakers. But thanks again, it was really wonderful.